Good evening, all. So I welcome you all from Yashoda Group of Hospitals. So every Tuesday we discuss important exam point of view pertinent topics. So today we'll be discussing nosocomial meningitis. And to take us through, we have got two senior examiners, Dr. BG Thomas Philip. He is a senior consultant in Rajgir Hospital, Alva, Kochi, and Dr. Chaitanya JSK. He is senior
Hello.
consultant, head of department, Gachibowli Kim's Hospital. So I welcome you both all, sir. And to take us through, we have got our resident, Dr. Priyanka and Dr. Pradeep. They are IDCSM resident at High Tech Hospital. So both of you can start the case. And sir, you can start the examining. Over to you, Dr. Priyanka and Dr. Pradeep.
Yes, sir. Thank you, sir.
You can
Good
start
evening.
screen sharing.
Good evening, Priyanka. I got your call and I got your, case summary. You can go on with the presentation.
Yes, sir.
Yeah, you can start.
Yes, sir. Here is a 38-year-old male patient who presented with 2 days history of fever and altered sensorium since last 1 day. History of presenting illness. Actually, the patient presented with sudden onset weakness of left upper and lower limbs 12 days back, and he was evaluated in outside hospital. Evaluation MRI revealed right gangliocapsular bleed with intraventricular extension and significant mass effect. In view of neurological deterioration, he underwent a decompressive craniectomy with clot evacuation. And followed by that, because of the delayed neurological recovery, tracheostomy was done 3 days later. And following that, he was shifted to a rehab center with a GSS of E3, VT, and M4. Whereas now he presents with complaints of fever since 2 days and altered sensorium since 1 day. And he was brought here from the rehab center. Past history is a known case of hypertension with no other comorbidities. And he's a chronic smoker and alcoholic. And family history was nothing significant. Coming to general physical examination, he was moderately built and moderately nourished. He was tracheostomized, and there is no pallor icterus, sinuses, clubbing, lymphadenopathy, or pedal edema. And his vitals were, he was on presentation was tachycardic. His blood pressure was 130 by 37 by 70 mm of mercury, respiratory rate of 30, and he was febrile with a temperature of 105 degree Fahrenheit. And his saturation was 98%. Because of his he became atachypnic. He was taken on BiPAP and shifted here from the rehab center. In the respiratory system, there was bilateral equal hereditary and with no added sounds. Cardiovascular system, S1 and S2 sounds were heard. There were no murmurs. And abdomen was soft. There was no organomegaly, no guarding or rigidity. Coming to the central nervous system examination, his higher mental functions, he was drowsy and his responsiveness was very poor, and he was not arousable on verbal commands. His GCS was E1, VT, M2 at presentation. And cranial nerve examination, his pupils are equal and reactive, although the Dalsey response was kind of sluggish, and extrapolate movements we couldn't assess because of his poor neurological status. And corneal reflexes was there, but it was kind of diminished, and gag reflex was present, and he was tracheostomy was in situ. Coming to the motor system examination, his muscle was bulk was preserved in all 4 limbs, and tone was there was increased tone on the left upper and lower limbs compared to the right, and the power was we could access like when there was withdrawal to pain in the right upper limb and lower limb, whereas there was minimal response to pain on left upper and lower limb. So there was definitely a deficits on the left side, sir. Coming to the reflexes were brisk on the left side, whereas they were normal on the right side. That is the biceps reflex, triceps, supinator, knee, and ankle reflexes. And plantar response was plantar response was flexor, was left was extensor. And sensory system we could not assess because of its poor sensorium. Meningeal signs assessment was also limited because of his depressed consciousness. And we did the ONSD measurement. The right side, the ONSD was 0.59 centimeters, whereas left side was 0.54. So this is the history and presentation. And after this, we want to sum up this. We want to go for a differential diagnosis depending on these presenting complaints and the examination. So one of the differential diagnosis depending on this work, like initially we
Summarize, just summarize. Don't read out, but just summarize your understanding of the patient head. So suppose you are there, intensive is there on that day. If you are receiving this patient, how would you sum up to your consultant?
Sir, a 38-year-old middle-aged man was a chronic alcoholic and smoker with a 12 days history of presentation of
Case,
weakness.
38-year-old who had suffered a recent stroke, tracheostomy, hospitalized.
Yes, sir.
Yeah.
And with acute presentation of altered sensorium and fever since 1 day. So with and is febrile. Right now is febrile with the temperatures of 105, so very high fevers, and he has left-sided hemiparesis, and with decreased GCS even VT and M4. So
You also said he is tachypneic
and tachycardic.
hypoxic. Yeah.
His saturations were maintained, sir, but he was tachypneic and tachycardic.
Tachypneic, but you said you had a lot of coarse crackles on side air entry reduced. You have to keep him on BiPAP, no?
Yes, sir. Like because of his tachypnea, we had to.
Yeah, that's right.
Yes.
No, at this point, you should have everything. No, somebody who has been in hospital,
Yes,
you
sir.
should have. He should be having some catheters.
Yes,
Drain.
sir. Urinary catheters
Ah.
and tracheostomy in situ and IV lines. So, depending based on these findings, sir, my differential diagnosis would be like there could be some underlying infections like like maybe hospital-acquired pneumonia or ventilator-associated pneumonia. Surgical, because he was operated, sir, it could be surgical site infection because of fever and altered sensorium, and it could be sepsis, septic encephalopathy, and because there was a bleed, there is a chance that there could be a rebleed because he's a non-hypertensive also, and there could be a offset hydrocephalus with raised ICP.
Okay.
At this point, what did the patient have a weakness when he was discharged initially? And how many days was he in the, this acute care facility, this rehab facility before he got readmitted?
Sir, three days history only, sir. He was 12 days back. He was his presentation is 12 days ago only, sir. So after that, till last 3 days, like after about like 10 days, he got shifted to rehab. But in rehab, his stay was very brief for 1 to 2 days, and then he
days
developed. Yes, sir.
And was the weakness pre-existing during the time of initial hospital admission?
Yes, sir. The
weakness was associated with the bleed.
Yes, sir.
Okay. Okay. So any X-ray finding which will corroborate with the chest examination finding?
Chest X-ray was normal for this patient.
X-ray was normal.
Yes,
So it was just basically he was on a tracheostomy.
yes, sir.
Yes, sir.
Okay. So we were given your differentials. So what is the differential which is at the top priority? Because now you are around 6 or 7 differentials. You cannot. It will be very difficult to go about eliminating each of them.
Because the fever is one of the pathognomonic signs, which are signs that is 105 degrees fever. It is not explaining because of the sepsis, sir. It could be a central cause for the fever. It is one thing that is going in favor of that, sir. So it could be that this decreased sensorium could be because of any acute bleed or a CNS infection with increased raised ICPs. That could have been the cause for the central fever. And fever as such could be because of various other causes, like
Yeah.
because he's having tachypnea. We are also thinking in terms of hospital-acquired pneumonia. And because he's also having catheter urinary catheter in situ, it could be a UTI, overlapping of a UTI infection. Sir.
How much was the saturation? I mean, without oxygen or whatever, with oxygen?
Sir, he was requiring minimal oxygen support, sir. With
Minimal
that,
oxygen.
yes, sir.
That has been
Which
the
does-
same while at your hospital, while at rehab and while he's back, or it is worsening?
Sir, oxygenation was not a concern, sir. The mainly concern was his tachypnea and sensorium, acute change. So that is why he was connected on BiPAP, sir.
BiPAP mainly because of work of breathing and tachypnea, which
Yes.
is probably related to the high fever.
So
Something else, especially in the subset of patients with fever where you are unable to localize specifically to particular area, what other causes of fever can be there in this group of patients, which is often neglected?
Like any hematoma in the like
So we
candula
should also think about,
thrombophlebitis,
we should also think of non-infective fevers sometimes, like
thrombophlebitis,
patients. Sometimes there could be
DVT.
yes, those things, yes. DVT, sometimes infective, but some sinus infections. They would have been on an nasogastric tube for a while. The sinus infections, all these bed sores. You have mentioned anything about beds, pressure sores?
Patient is not
there were no pressure sores.
Okay.
Okay. So how do you go about eliminating this? So you said your X-ray was clear, and then you do probably blood cultures, urine cultures, isn't it?
So,
And then regarding the possibility of post-operative meningitis, how do you go about, checking for that?
so
CS, according to diagnose this hospital acquired ventriculitis or meningitis, according to CDC guidelines, we should have the organism cultured from the CSFs, or we should have age above than 1 year age, means we should have fever more than 38 degrees centigrade or headache, or we should have meningeal signs, or CNS deficit should be present, or other things like any one of the following, like gram stain organism should be present in CSF, and in
No,
CSF.
those are criteria. From here,
Yeah.
how will you take on this patient? What is your next step?
Well, sir, because we are suspecting infections, like first thing is we'll take the samples and send for culture, sir. Like we have
Blood
taken cultures for blood, urine, and tracheal cultures, and sent for. After that, within 1 hour, our target is to start empirical antibiotics because of fever. We are suspecting in terms of even sepsis could be the cause, septic encephalopathy. So our priority was to start empirical antibiotics. We started meropenem and vancomycin, sir, within 1 hour, and we also got the imaging done to see any rebleed was there. The lab investigations we collected, sir, and it came to be like there was neutrophilic leukocytosis, and he had AKI, although it was oliguric AKI he had, and we got ABG, arterial blood gases, because he was tachypnic also. Then that there was no signs of any hypoxia, and or more respiratory failure concerns were not there. So unlikely that the patient has any underlying lung infections, because the chest X-ray was clear and the EBG is showing good oxygenation. So we definitely have some kind of infection because of the neutrophilic leukocytosis, sir. And we would like to work up as we have already started empirical antibiotics. We would like to further follow up on the cultures And also the imagings of the CT, we got a CT brain of this patient, sir, to further workup regarding this. And in the CT brain, there was a large frontotemporal defect secondary to the craniotomy, and there was there was residual bleed with very bleed edema is there, and transcalvareal herniation we can see, sir. And there were definitely hydrocephalus signs on the left ventricles with shift of midline shift to the right. So there is this could be explained by the raised by the could be explained by the hydrocephalus and raised ICP features. And because with this, we took a neurosurgical consultation because it was such a midline shift and a transcalvareal herniation, and we thought we could go for a surgical consultation to do something about this. Because there was also features of hydrocephalus.
So how did you go about taking the CSF sample?
Sir, actually, because of this features, there was a planned surgery to insert EVD drain because there was hydrocephalus. So we didn't right away go and do a lumbar puncture, sir.
LV.
ONSD was also.
Yes, sir. And yes, ONSD was also high. So that was also one of the features towards the raised ICP. And we took the call for operative intervention like EVD insertion and OMIR insertion. And because that was discussed, we thought meanwhile, when during the process of EVD placement, we'll take the CSF sample and for analysis.
Okay.
Can you go to the CSF findings?
Sir, this is
sorry.
we got the CSF analysis done. The appearance was CSF was turbid with pleocytosis, mainly neutrophilic, and there was decreased sugars and raised proteins, and the cell index was 3990, and ADA was low, and we couldn't. There was no AFB seen, and there are no fungal elements seen. And gram stain, there were polymorphs in the gram stain with gram-negative coccobacilli and occasional gram-positive cocci in pairs. And we also got expert MTB, which was negative.
How do we calculate the cell index?
So we will take WBC count in CSF and RBC count in CSF divided by WBC count in blood and RBC count in blood, sir. And it should, if it is more than 5, it is positive, sir. We have here like 3,990, sir. Very high suspicion of bacterial meningitis.
Okay. What precaution should you take when you did you calculate it manually or you get the result from the lab or?
We did it.
Sir, we got.
So how is the CSF WBC reported? It is in. It is what is the units in it reported?
Cells per
millimeter.
Cubic mm.
And how is the RBC reported?
Millions per cubic mm.
Millions per microliter.
Microliters.
Did you make correction for the units when you calculated this? I think 2,900 is very high. I don't know whether that is corrected. So that has to be checked, because the units, the basal sampling is different. One is in millimeter cube, other one is in microliters.
And usually one more difference is when you take a lumbar sample, cell counts can be high compared to EVD. When you are directing sampling from ventricle, usually cell counts you may not expect as you use criteria for bacterial meningitis. Ventricular samples usually have less cells.
Less.
Here, when you are doing this index, you have to match the units also, how they are measuring.
So probably, I mean, we have usually seen units in the range of 10, 20. I mean, I don't know whether we have seen thousands and 3,000. Okay, anyway, that's okay. So yeah, so you got a gram stain also, which is showing coccobacilli.
Yes.
Gram negative,
Yeah.
isn't it? Yeah. Okay. So
If I can stop a step before, You have done a CT, that too, especially because you wanted to rule out a bleed. Yes.
Yes, sir.
But suppose say your patient had a drop in GCS. Is there any other modality you would have considered if it was some other patient? Where you are suspecting meningitis, what other imaging modalities you would have chosen, and what would you look in for finding supporting your cause?
MRI brain with contrast.
What will you look into that?
Enhancement.
Suppose say MRI was not feasible because of some inotropes and all. First, we'll finish off CT. If you're doing a CT, what features would you be suggestive of an intracranial infection? What findings you might find for a post-op patient or a post-hemorrhagic stroke patient? What features would suggest you there could have been an infection?
It could be basal exudates, the basal systems exudates, and enlarged ventricles, secondary to obstructive ventricular, secondary to the
Acute? Yeah. Okay.
enlarged ventricles and
Sometimes when associated with poor GCS, you find an increase in cerebral edema, which is not only close to the pathology site, like a bleed or something. You might see a diffuse cerebral edema sometimes. Then, as you said, fullness of ventricles, obliteration of CSF spaces. Then you might also find abnormal collections sometimes. Surgical bed, subdural empyemas come post-op. There could be collections at the surgical sites under tension. All this can be seen even on a plain CT. If you do a contrast, then you might find meningeal thickening and all. So CT or MRI, which would give a better picture for an infection in post-op?
MRI with contrast would be more sensitive.
Again, what will you look for in MRI?
So leptomeningeal enhancements, that is enhancements all along the cerebral convexities along with the insinuations into the gyri and Sylvian fissures.
Okay. Ultrasound can help in any way?
Sir, you can use transcranial Doppler to see any features of raised ICP.
Okay.
That pulsatility index we can calculate, sir, and to know whether definitely we have got any raised ICP, which can lead to the one of the differentials of meningitis, or could be an bleed.
Any CNS pathology. Sometimes when CSF is so turbid, as you said, no, with such a post-op defect, even you can see some internal echoes in the CSF or ventricular space also.
So
when post-op defect, when craniectomy is done, you can use ultrasound also to see if the CSF is turbid. If it is very turbid, you can even find internal echoes in that. Okay. Sir,
Yes. I think you can proceed because most of the discussions would come in the treatment and other diagnostic criteria.
Yeah.
Yeah. So you did the CSF culture, isn't it?
Yes, sir.
Okay.
So
this culture was done on the same day as the presentation.
Yes, sir. It was sent on the same day.
Same day you got a.
Okay. Sir, patient was continued mechanical ventilator and we continued empirical antibiotics. However, his sensorium continued to be poor, and we got back the CSF culture sensitivity, and there was a growth of Acinetobacter pneumoniae, which was carbapenem resistant, and it was sensitive to minocycline, and colistin sensitivity was intermediate. So coming to the diagnosis, it is a right capsular ganglia intracerebral bleed with intraventricular extension, obstructive hydrocephalus. It is a state post decompensated pneumotomy and claudication, which is complicated by healthcare associated ventriculitis or meningitis. due to carbon resistant Acinetobacter, sir. It could have led to his septic encephalopathy and non-allegoric acute kidney injury.
So you were telling about the diagnostic criteria for post-operative meningitis, no? So this was, you are discussing the IDSA criteria.
Yes, sir.
CD.
So what, yeah, I mean, what is the main requirement for that? You go by,
Organisms,
organism should be grown in culture.
culture, CSF culture
Yeah.
should be grown.
Yeah, and then you other supportive criteria, like you have the definitive case of meningitis, and the probable case. Probable case where culture has not yet come probably, or it is yet to be reported, or it is, I mean, culture negative, but you have CSF pattern which is similar to the infection.
Okay.
Yeah, but the problem with post-operative meningitis, why the culture is being emphasized so much? Why not you can go by CSF cell count, WBC, all these things?
Because of recent surgery and any hemorrhage, all the counts will be like it will be not
Yeah.
accurate.
Yes, and yeah, and they will have ventriculitis and all because of the blood and all these things, post-surgical inflammation. So counts and this alone is is supportive only. So if the patient had been on antibiotics maybe 2-3 days, he has received antibiotic already. Would you like to do any other investigation other than culture? Culture may become negative, especially if it is not a very resistant organism. Like most of the, part of the post-operative meningitis are gram-negative organisms, but some may be, staphylococcus, cons and all. So they may become negative after 2 or 3 days. Culture negative. So any other investigation you would like to do, which is more,
CSF lactate will be very diagnostic, like more than
CSF lactates and CSF procalcitonins, we can get it done. CSF lactates of if it is like less than 2, it is like it rules out any infective cause. 2 to 4 is still we have ambiguity, but more than 4 to 5 lactates, it indicates more sensitive to
high probability of infection. Okay.
Yes.
And same again with CSF procalcitone also, it can give a clue towards infection, but still you will not be able to identify organism. You will have still a wide range to treat. So other than culture, what else we can do, which is done nowadays?
So we can get a PCR.
Yeah.
CSF multiplex PCR test to see for any organisms.
Yeah. So, about PCR, you can have either the open panel or you can have the multiplex panels. So multiplex panel, which is the commonly used one, and is there any limitation of that panel when you come to CSF post-operative meningitis?
Like all parasitic infections can't be seen. So normal, what we see organisms like community. All these
which CSF panel you use commonly? What is the panel which is used?
What do you use in your hospital? What are you using?
So multiplex CSF panel in our hospital, we get the community organisms mainly, sir.
Biofair.
Biofair.
So that is the Biofair meningitis panel.
Meningitis
it's not commonly occurred. So what is the problem with this panel here? Limitation. Will you send a Biofair meningitic panel for this patient, or is it useful?
So it may not be useful because it may not cover the organisms that we want to detect, like the staph aureus and gram-negative bacteria.
They are not covered in that panel. Okay, good. Okay. Yeah. So what else can you do? Other than that, which panel you may send?
You can
though it is an off-label use, you can use the BCID panel. And BCID panel has the most of this gram-negative organisms, staph aureus and all. So it is, though it is actually meant for the blood culture use, it can be used off-label, and that performance characteristics are not bad. So many times, patients on antibiotics, you may still get a negative culture. So using the BCID panel is useful, especially if you are not putting an EVD, you're taking the sample by lumbar drain, lumbar puncture. You may not be able to access again and again. If you have an EVD, you may still repeat the culture and repeat the sampling and take the PCR later on. Okay. Dr. Chaitanya, you have anything?
Yeah, no, sir.
Yeah. So now we have covered that aspect. Yeah. So now coming to treatment, shall we go to the treatment side?
Yes,
or,
sir. Yes.
Yeah. So now you identified the organism, which is the multi-drug resistant or carbapenem resistant Acinetobacter. So what is if you look at the whole, post-operative meningitis, what are the common organisms you see?
Gram-negative bacilli will be hitting
Yeah.
like mostly other countries, staph aureus, staph epidermidis, and propionibacterium. So in our country, like Acinetobacter and Pseudomonas, Klebsiella, E. coli.
Yeah. So these are the usual culprits. Okay. So now regarding this organism, what are the special challenges you will face on treatment?
Resistance.
Sir, Acinetobacter baumannii, this organism actually it is either sensitive to the our standard antibiotics, or when if it is resistant, it will be XDR or MDR or XDR resistance. So we will have a very narrow options,
choice
very
of
few
antibiotics
options
which you can use.
about antibiotics. And one more thing is in CSF it is more like it is diagnostic, but if you are getting in blood and all, it could because it is also possible to be a contaminant in the other isolations. So we won't be knowing whether it is true isolation
organism or is a
contaminant.
colonizer, especially this is when it comes to respiratory cultures and all. Yeah. Okay. So this is carbapenem resistant. What are the common mechanisms of carbapenem resistance in Acinetobacter?
OXA, pouring channels closure, reflex pumps.
Yeah, and they are there, but mostly, they are again carbapenemase producers also. Carbapenemase production is there. On top of that, there is reflex pumps and Warren law syndrome. Okay. So you said this is colistin intermediate. So this is by a Vitek result, or what kind? What was the culture method here? Sensitivity.
Sir, it was Vitek method only, sir.
So white, yeah. Okay.
But actually we have to.
Chaitanya, do you have any questions at this point? Because when you are saying about carbapenem, colistin intermediate, and all these things.
No, sir. I think he was trying to tell something regarding Vitek.
Yeah. Tell me. Okay, you can go ahead. Yeah.
Sir, for colistin, we have to do a micro-broad dilution technique to see for the resistance rather than relying on Vitek. So to see for the actual.
Vitek will mostly above MIC of 0.5, it will always report as intermediate only.
It's because the latest CLS revisions previously which were being reported sensitive, now up to 2 is come as intermediate. Like sir, 0.5 to 2 is come as intermediate. Previously, less than 2 was given as sensitive. Now I think it is 0.5 to 2 is intermediate, and more than 2 is resistant. So still intermediate, we can still continue to use.
Yes, that is the thing regarding Vitek. Yeah. So now, how did you go about treatment? So you have colistin sensitive, colistin intermediate, and minocycline was sensitive, and meropenem is resistant. So now you have to change
your blood cultures.
Blood cultures didn't do anything, sir. It was sterile.
Okay.
And other cultures, respiratory, urine,
Negative.
It was
they
negative.
were all
Sir.
negative.
Urine we didn't send because there were only 4 cells and it was unlikely. Sir.
WBC.
But blood we sent, it was sterile.
Okay. And TVD has been
urine.
placed.
Yes, sir.
Yes, sir. EVD was placed with the Omayo reservoir, sir.
Reservoir was placed and you used a spike to drain.
Yes, sir.
Duration, you have not mentioned. How long have you given antibiotics? What is the recommendation?
Sir, recommendation for gram negatives is to give for 10 to 14 days, but some guidelines even 21 days we have to continue for the gram negative vaccine, sir. So we had continued this drug for about 14 days, sir. After that, patient wanted to go because
Get
they
discharged.
had symptomatically better. They wanted to go to rehab center, sir.
IDSA says it is 3 weeks for gram negative, no?
Yes, sir. 21 days.
21
20
days.
21 days. Yes.
Current guidelines, post-op gram negative infections, 21 days.
21 days. Yes, sir. 21
And
days.
you have combined colistin with intrathecal. Can you explain why?
Sir,
Achieve good CSF concentration, sir. Because if we give IV, it can't reach the enough concentration to act. So we have given intrathecal along with the IV, sir. And some studies have been done like while giving this IV and intrathecal, cure rate is like 94% like that. So.
So intrathecal.
When you give IV, I didn't get the last.
IV and
when you give
IV and intrathecal.
Yeah. So what is the dose for the intrathecal which you give?
For colistin 10
we gave 10 mg intrathecal.
10 milligram. That's the standard dose. Every day or only one time?
No, sir. No. We
How
gave
many
for
days?
we gave for about like 7 days we continued.
7 days for intrathecal and then intrathecal plus IV.
No,
I
sir.
think intravenous is 3 weeks. Intrathecal, I think 10 days you have to give, if I'm correct.
Yeah, 7 to 10 days.
7 to 10
after, I mean, 1 week after the culture is negative. So,
Yes.
yeah.
What other drugs you can use intrathecally?
So you can use vancomycin, tobramycin, gentamicin, amikacin, polymyxin B.
Any
Colistin.
advantage between poly B and colistin to give intrathecally? Can you give polymyxin?
We can.
Yeah, we can give. It's a prodrug. Even poly B can be used.
Colistin is a prodrug, whereas poly B is an active drug. So that would be an advantage.
Yeah.
So, and what is the outcome? How I mean, you responded to the treatment, sensorium improved. You were saying the sensorium improved, no?
It's a sensorium improved, sir.
Improved.
Yes.
Yeah.
Like we got sensorium improved to like E3VT M4, sir. And he was discharged to rehab.
Any role for steroids in this patient?
Sir, no, sir. Steroid, the studies, whatever have been, the benefit have been in with the pneumococcal pneumonia. And
To initial stage, if we give the dexamethasone, like in New England Journal, and they have said that there is a use, and in Cochrane study also, but there is no decrease in mortality.
If you had to give, what would be the only indication where you would have given steroid in this particular patient? If there is very diffuse cerebral edema, life-threatening edema, post-op already decompressed, even there, I don't think there is any evidence to support steroids. It is only found to increase mortality in nosocomial meningitis. But usually people find that being the alone indication where edema is so severe out of meningitis. When they are initiating treatment, they would consider a short course. But still no evidence, and it is found not to be used. Suppose this patient had a shunt already. There is an indwelling catheter already. What you would have done?
And if it is like VP shunt, we will know the symptoms, sir. Like if it is from source like abdomen, patient will be having like abdominal tenderness and symptoms. So that time we will remove the drain, shunt, and we will give the EVD drain, sir. If there is need for like hydrocephalus, if we want to remove the fluid, then we will give the shunt, EVD drains.
You have to remove the device.
Yes.
Yes.
Yeah. Okay.
So one more thing. So if if this patient was having an EVD in the beginning, for the bleed, intraventricular bleed or something, the patient is having an EVD. Okay, so they may be being the EVD for 1 week, maybe a few days. So how do we go about? What are the preventive measures to prevent post EVD insertion ventriculitis? What are things you should be careful?
Some studies have shown that like while we handle the EVD drain, we should have double glove techniques, because when there are holes in gloves also, there is chance of getting these meningitis chances. By using double glove, we have to remove the first glove, and using the second glove has helped to prevent this hospital-acquired ventriculitis or meningitis. And there should not be any repeated sampling. We should be very sterile, and if any disconnection is there for more than 2 times, we should completely remove that, has also been suggested.
Yeah, that's the most important thing, is that minimize the sampling and sterile technique and chlorhexidine-based, chlorhexidine-based dressings over the site. And and surgeons will do the tunneling. Usually they'll put the tunneled insertion. Yeah. Okay. Okay. Anything more, Chaitanya, if you want to add?
So, I mean, how did you prognosticate this patient when you diagnosed the Acinetobacter in CSF? How did you prognosticate the patient?
Prognosis, like all midline shift is there, like hydrocephalus increased, ICP was there. So we have given like, and crab was there in the CSF, sir. So poor prognostication.
Okay.
Yeah.
But usually infections are reversible, no?
This crab.
And he had M4 response before. By 10th day of stroke, his GCS came up to 10, maybe E3, M4, VT. So somewhere between 8 or 9 is his GCS. He is improved a bit. Now he is down out of an infection. You want to prognosticate poorly, or you want to give some hope that this is a correctable cause and all? No?
He's having massive hemorrhage with like there are so many factors, sir. One thing is peri-bleed edema is there, and there is also transcatheter shift with hydrocephalus, and with the gram-negative infection, that also XDR organism. So these are the risk factors which are goes against like a favorable outcome. So these are the things we would explain to the attenders. And say give a initially we had given a guarded prognosis only, but he responded very well to the antibiotics and he recovered.
Yeah, that's what. See, even in if you read through subarachnoid hemorrhage also, when you're prognosticating, they say you'll have to take the GCS after draining hydrocephalus to prognosticate. Hydrocephalus is something which immediately can impact their sensorium, and once drained or diverted, immediately it can bring out some difference. So with hydrocephalus GCS, usually you shouldn't prognosticate. And here, when you have hydrocephalus and you have some infection which is correctable, I mean, which if improves can improve him, no? You can prognosticate guardedly, but you should not push them towards not continuing care.
Yes, sir.
We'll have to see. We have to wait for response. It being a transient thing, if time permits, maybe he'll improve. And usually, we should also tell when you are giving intrathecal therapies, there would be transient worsening in sensorium further. That we commonly notice when we are giving intrathecal colistin and all.
Yeah, what is that due to? Can you answer that question?
Due to immune reconstitution symptoms.
Yeah, intrathecal drugs can cause chemical ventriculitis.
Meningitis.
Chemical
Yeah, I mean
meningitis.
ventriculitis or meningitis. So that can also, when it is given in patients who have reasonably normal disease, also they can deteriorate
They
initially.
can deteriorate.
Yeah, that is
So
also
when other
important to tell.
systems, so when other systems are intact, immediately we need not give up. Actually, we can wait till we discontinue such ventricular toxic drugs. Anything else you could like to say?
Yeah, I think this has been thorough, well answered. Prepared case, so it's okay. Yeah, so mostly good discussion. Just one more, the drug that is not available here. So if this was not if you are discussing a case of a crab, VAP, or any other infection, crab VAP is a difficult to treat infection. So is there any drug, newly available drug, which is better than colistin and all these combinations?
Sulbactam,
This is our-
durlobactam combinations.
Yeah, so that is. Yeah, you can go ahead and tell.
In the IDSA guidelines, they have told sulbactam, durlobactam combination, if it is available, then we can use it. But in Indian settings, sir, sulbactam itself, 9-gram dose with one more antibiotic like minocycline, tigecycline,
Combination therapy.
combination therapy can be used. And that sulbactam itself has a intrinsic activity against Acinetobacter baumannii.
Did you use sulbactam in this patient or only colistin and minocycline?
In this we didn't do, sir. In other crab pneumonias, we have used.
You can go up to 9 to 12 grams of sulbactam per
Yeah.
day. One more drug which has Acinetobacter coverage is the new one, cefepime zedibactam.
Yeah, that is yet to
Also,
be again yet to be released.
Yet to be released. But that's one new drug which is coming up. Cefepime also has meningeal penetration and also has Acinetobacter cover. That could be one new thing which could, I don't know if I'm not still sure about zedibactam and the whole thing, whether it is penetrates meninges, but cefepime per se crosses. So
yeah.
Suppose, if you have to start empirically for a patient who has not been exposed to any antibiotic till then, you would straight away jump onto meropenem, or is there any other drug which you would like to try for a hospital-acquired meningitis? Somebody having EVD, 4th day, 5th day, you suddenly, before removing EVD, somebody did cell count or lactate when they removed EVD because he started having fever, they are abnormal. How do you start? You straight away go for meropenem or?
Sir, because it is we are suspecting it as healthcare associated meningitis or ventriculitis. According to guidelines, vancomycin with the Pseudomonas coverage we can use, sir. Other drugs like cefepime, ceftazidime we can use.
Cefepime, vancomycin.
Vancomycin to cover for gram-positive Staphylococcus aureus MRS.
Okay. Any complications of meningitic dose, meropenem, meningitic dose, in all these things?
Sir, with atrapinum, there are higher chances of seizures, sir. With meropenem, there could be seizures, but the reports are is low. Incidence is low, sir, compared to atrapinum.
At higher doses, no? At meningitic doses,
yes, sir. There is
neuro problems
chances
are common even with meropenem.
Yes, sir. It can lead to seizures.
We had at least 3 patients. I have seen at least 3 cases of non-convulsive status. That's one thing we need to monitor when we are dealing with infections. Mostly drop in GCS, poor GCS, till these drugs go. I think sometime we'll have to do a EEG also, because they're more prone for seizures. So that's one thing you have to monitor also when we are treating a hospital-acquired infection treatments, in meningitis especially. Sir, anything else you would like to add on this?
Even the same thing holds true for cephipime also.
Yes,
Also
cephipime,
high
yes.
seizurogenic, it can cause it. And this, as Dr. Chaitanya told, it's unexpected change in GCS. The patient is doing good for a few days and then changes in GCS. One either is again obstructive hydrocephalus or seizures. These are the things which you have to rule out. Seizure can be drug induced. That's very important. Yeah, I think this is fine. We have recently covered most of the diagnosis, differential diagnosis, treatment. Every part has been covered. Yeah.
So there's a very nice discussion. Few points to add, sir. So thing is that like our biofire film array, that doesn't cover mostly what we are looking for, predominantly gram negative and all. So most of the time when we stuck there, so we don't have any findings. So probably apart from that, we can have next generation sequencing if we really wanted to know what are the organisms. In some cases we have sent it. The only difficult problem is the turnaround time. It will be some cases 3 to 5 days probably, but in few cases where we are suspected and the family wanted the diagnosis, the organism, so we got a positive identification in that situation. The other thing is that now to differentiate between the post-operative cell pleocytosis and meningitis, I think CSF lactate has a major role. So CSF lactate and procalcitonin, not very commonly. Lactate has been very thing used. Anything 4 millimole
More
per
than
liter.
4 minutes.
So it is a like high suspicion. You have to straight away start with the antibiotics and all. And intrathecal, when the load is high and you are thinking that probably might be dealing with resistant. As we know, hospital acquire mostly predominantly are resistant gram negative bugs. So if possible, better to start intrathecal cholesterol also. The dose, I think we can go up to 5 lakh unit. So OD in the dose, and the upper limit of duration they not mentioned. Various studies are mentioning different thing. Up to 10 days or up to 2 weeks also, there are some studies are mentioned along with the IV. The other thing is that other intrathecally we give, especially if Yashoda crab, we're looking at TG cycling. Minocycline is not very much studied, and TG has been studied in the dose of 10 milligram OD. So in few cases where we got same Acinetobacter, so what we used to give IV colistin along with the IV TG cycline. The TG was sensitive, so we used to give both. Either morning time we used to give intrathecally colistin, and after 12 hours kind we used to give TG cycline after 10 days. So after say a couple of like few hours, so same day in the evening. So approximately we give probably 10 days of whole the therapy along with the IV. That is probably one thing we have to look for. Poly-B also we are given, but Poly-B not much of studies has been there regarding the predominantly it is a colistin only. So Poly-B can be given, the doses not very sure, but probably 1/3 of the IV doses have been tried in the various studies, but predominantly it is colistin only. Rest all, I think the same very well covered, sir. So both of anything point we can add on. So as if there is not much of question from audience also. So anything, sir, Thomas, sir?
No, I think it's fine. We have reasonably covered what all can be done in this much time. Yeah.
Right. Anything, Chaitanya?
Yeah, I think if you had experience giving intrathecal injection anytime,
Yes, sir.
how will you do?
Sir, I will wash up like any other procedure, sir, and donning with the gown, with first with the mask and head cap and donning, and with like gown and gloves, strict as 30%, just like we do in any other like central line procedures. So we follow, sir.
No, later. That's where the main point is. How much you Do you
Sir,
give
after
fish or
after
not? Will you draw some sample before or
Yes, sir,
after?
we'll draw and
All those things I want. I mean, especially I'm asking just for the audience, whoever is listening, it will be useful for them.
sir, sample if to be drawn first, sir. Then
How much sample you will draw?
2 ml.
Okay, 1 ml or something. It is based on the catheter length and how much stasis fluid is there. You'll withdraw. Next, you said 10 mg of colistin. In how much volume you will prepare it? Because you are giving inside, you may not be able to give large volume, no?
Yes.
yes, sir.
This is here.
1 ml. Usually take the 10 mg in 1 ml, give it, and followed by 1 ml again saline to flush it out of the catheter into the ventricle. And then close the drain for how long?
About 15 to 60 minutes. 15 to 16 minutes.
Okay. I'm not find any reference, but as a practice, we used to close it for an hour and then again open if it is necessary. If patient is on a continuous drain, then we used to close it for an hour and then open again. If we are using
1
the
hour is
reservoir
the
only for
average
drug
standard.
if we are using it only for as a reservoir only for drug administration, that's a different case. But if not, we used to close it for an hour minimum. Okay, and all these things, before you open the drain, you have to keep things prepared ready. Your syringe to withdraw, then your drug loaded with 1 ml drug, and then your flush. All 3 syringes should be ready before you touch the patient. Okay.
Yeah, that's a very important discussion. We didn't do it before. How the drug is administered, you should know clearly what is the dilution, how much time you should close the drain if you're using via EVD, those kind of things. Yeah.
Thanks.
So I think that is a really practical point. So where we have to consider. So I think there's a very good 1 hour case discussion. We are trying to cover almost all points, including antibiotics and all. So hope this will help to all and our participants. Thank you, sir. Thank you, Thomas, sir, and thank you, Dr. Chetan, and our fellows, Dr. Priyanka and Dr. Pradeep.
Thank
I
you,
will
sir.
close
Good
this
night.
session.
Thank you.
Good night, everybody.
Thank you.
Thank
Thank you for calling us. Yeah.